Hello, everyone, and welcome. My name is Kathy Donaldson. I'm the program coordinator of the Perinatal Mood Disorders Initiative at Central Jersey Family Health Consortium. We're glad that you could join us today. This is our first webinar in the Maternal Mental Health Awareness series, which is for the month of May. And the series is called, as you know, Maternal Mental Health is the Heart of the Family. To the nurses in the audience, I wish you a happy early Nurses Week. And to let you know, every webinar will be recorded and will be available on YouTube as well as our website. So you can refer your friends to the website and to YouTube if they'd like to see the program, or if you'd like to listen to it again. Please put the questions for our speaker today in the chat, and we'll get to as many questions as we can at the end of the session. And now I'd like to turn it over to my colleague, Karen Stern, who will introduce today's speaker.
Thank you, Kathy. Good afternoon, everyone. Thank you for joining us for the first of 4 webinars to recognize Maternal Mental Health Month. I've been really excited for today's presenter, Carolyn Flynn, because I first heard her speak back in February, and I was absolutely fascinated by the information that she had to share, and I know that you will be too. Let me just read her short bio, and then we'll get started. Carolyn Flynn, MALAC, is the director of the START program and an early relational health clinician at the Center for Great Expectations. Carolyn earned her master's in counseling from Kane University and is a licensed associate counselor in New Jersey. Her passion for working with pregnant persons began as a certified doula, providing education and support during pregnancy and childbirth since 2006. Carolyn is a strong advocate for changing childbirth practices to become more equitable, family-centered, and trauma-attuned. As a senior trainer at the Satari Institute, she has presented both locally and internationally on topics including early relational health, traumatic childbirth, and intergenerational trauma. Carolyn is rostered in child parent psychotherapy and currently a fellow in the UMass Infant Parent Mental Health Postgraduate Certification Program. Carolyn is a mother to 3 spirited children and enjoys writing, drumming, and camping. I now turn the program over to you, Carolyn. Thank you so much.
Thank you, Karen, for that very generous introduction. I'm going to start by saying my 3 spirited children will be coming home from school at some point during this presentation, so my apologies in advance if there's any interruption. So they've been warned that mommy is working from 12 to 1, but we will see. So thank you so much to Central Jersey Family Health Consortium for inviting me here today to share this information. I'm super excited to talk a bit about intergenerational trauma and the importance of the parent-child relationship in creating the foundation for mental health. So with that, we will begin. I have no relevant financial relationships to disclose and want to just go over briefly our main topics for today's discussion. We will begin by exploring, just giving a little bit of an overview of the ACEs and the expanded ACEs and talking about how they are passed down between generations, which includes the mother's early experiences and the experience of trauma by the prenate during gestation. We'll also talk about traumatic childbirth within the modern medicalized birthing system and its impact on maternal, or I should say perinatal mental health. And then in turn, the importance of perinatal mental health on the parent-infant relationship and how that 0 to 3, that early relational, the early relationship between parent and child really sets the foundation for well-being throughout the lifespan. So I know that we have all seen this again and again, but still a very important starting point. So as many or most of us here are aware, the ACEs study was a foundational study conducted back in the mid-90s by the CDC and Kaiser Permanente that involved 17,000 participants and found that there were 10 early experiences that had an impact long-term within an individual's lifestyle. The study found that 1 in 6 respondents had experienced at least four or more of the following ACEs, for example, physical abuse, emotional abuse, sexual abuse, physical or emotional neglect, or experiences within the household, such as mental illness, divorce, or seeing the mother treated violently, among others. And we know that within an individual's lifespan, those early experiences have a strong correlation with outcomes across many domains. So behavioral issues such as drug use, addiction, smoking, etc., and then many different aspects of physical and mental health. Later studies are really starting to take a look at, why just these 10, albeit very important and very impactful early experiences? Well, what about the environment? Taking a look at adverse community environments. Future studies have looked at the effect of bullying and poverty, experiencing racism, having food scarcity, or experiencing community violence, and finding that, in fact, these also have a very strong impact on well-being within the lifetime. So in 2012, there was an additional ACEs study that was done in Philadelphia. The original CDC Kaiser Permanente study was done mainly on individuals who lived in Middle America, were fairly well resourced. The majority of participants were white and had access to safe communities and healthcare, different social determinants of health. So the study in Philadelphia in 2012 really looked at ACEs within an under-resourced urban community and found that there are additional ACEs that we need to consider. So feeling discriminated against, witnessing violence in the community, being bullied, having experiences of living in foster care. And this study found that within this Philadelphia community, the rates of ACEs were generally much higher. So if we move away from these expanded ACEs and go back into those 10 original adverse childhood experiences, they found that the Philadelphia study, 33% of respondents had experienced emotional abuse, as opposed to 10.6% in the original study. Physical abuse was 35% in the Philadelphia study, as opposed to 28.3% in the study back in the 90s. Physical neglect, 19.1% in 2012 in Philadelphia, and 14.8% in the CDC study. The highest ACE, the highest reported ACE in the 2012 study was witnessing community violence. 34.5% of individuals responded that they had experienced discrimination. So just kind of giving a little bit of perspective around these ACEs are really important in informing our understanding of how what happens to us when we are young impacts us throughout the lifespan, but that we really need to take a broader view in looking at a more diverse community and looking at that. Those 10 are important, but there are more as well. And so part of what we're going to talk about today is not so much how ACEs impact individuals within one lifetime, but how ACEs are passed down intergenerationally. So future studies have found that offspring of mothers who experienced ACEs, who had those 4 or more ACEs, had increased risk for poor physical, behavioral, and cognitive outcomes themselves. So the question becomes, well, if the infant themselves didn't experience those ACEs, how does that come to be? How is it that the mother's early experiences are passed down through future generation? And early theories around this, which still hold in future studies, are that the mother's early experiences led to poorer quality attachment between the mother and the fetus during gestation, and that this held true regardless of whether mom experienced DV during her pregnancy and during adulthood. So finding that what happened to mom when she was young impacted her attachment to the fetus, even if there was not DV during gestation. Also looking at how mothers with early adverse experiences would demonstrate increased maternal heart rate when their infants would cry. And so this being associated with lower maternal sensitivity and disrupted attachment system. Studies also showed that infants born of mothers with 4 or more ACEs showed poorer ability to regulate their emotions at 6 months and had increased levels of cortisol at 1 month of age. So taking a little bit of a look into the experience of the gestating prenate during pregnancy. Looking at how the developing fetus, how they experience the world through the experience of the mother. A really neat study that was performed back in 2010 had mothers listen to and watch a movie via headphones. So mom had headphones on, the prenate was not able to hear the movie ambiently through the mother's belly. And she watched 2 sound clips. The first was intended to invoke feelings of happiness. This was a clip from The Sound of Music. The second clip was from a movie called The Champ, which was intended to induce sadness in the mother, where the scene was a boy crying because his dog had died. And what they found was that, so they were looking via ultrasound at the fetal arm movements as mom listened to and watched the movie. In the sadness group, the fetal arm movements, so if you look at the graph on the right, the fetal arm movements dropped as mom started to watch the movie and experience those feelings of sadness. And the arm movements did not come back to baseline during the time of observation. When mom watched the happy movie, the Sound of Music, fetal arm movements went up above baseline and then came back to just about baseline, a tiny bit lower, but we can see there was an increase in the prenate's response and then coming back to normal. But with sadness, there was evidence of decreased reactivity and movement and not coming back to baseline. So the conclusion here is that without having outside stimulus, the infant was shown to react to mom's emotional state. So looking a little bit around other ways that those early experiences of mom can be passed down between generations. A study back in 2018 found that those early experiences of mom caused changes in her HPA axis. So a little very brief, very oversimplified explanation of the HPA axis. The hypothalamus, the pituitary gland, and the adrenal glands are all part of a system that help individuals respond to stress. This is the way that our body communicates so quickly when there is danger that, let's say, for example, we are walking across the street, a car comes zooming down the street, that we jump back without thinking, without making logical decision. That HPA axis, the hypothalamus detects the threat, It communicates to the pituitary gland, adrenal, the adrenals secrete hormones, and we're able to have that fight, flight, or freeze response. And so these early adverse experiences caused a change in mom's stress response system, creating a more reactive, a more sensitive stress response system. And the stress response system involves increased production of cortisol. And so looking here a bit at how during pregnancy, if mom's HPA axis is more sensitive, more reactive, how that affects the developing prenate. So mom's body is going to be apt to produce more cortisol. And typically during pregnancy, the placenta creates an enzyme which protects the gestating prenate against cortisol in mom's system. This enzyme is called 11-beta-HSD2. And what it does is it oxidizes cortisol in mom's system to its inactive form, which is cortisone. However, adverse intrauterine conditions. So if mom is living in a very stressful situation, if she has food insecurity, if she's in an abusive relationship, what happens is the placenta downregulates that enzyme. And so the infant is not protected from the cortisol in mom's system. So we have sort of a double factor. Mom's HPA axis is creating more cortisol, and now the infant's typical buffer against that cortisol is downregulated. And what we know is that during gestation, abnormal levels of exposure to cortisol creates neurotoxicity, and it results in reduced fetal brain growth. So why would this happen? How is this adaptive? Let me go back here for a moment. I think this is on a later slide, but I'll go into it here. The theory is that when the buffer is downregulated and the infant's brain is exposed to cortisol and it then changes the way that the brain forms, it's creating an infant who is going to be adaptive to living in a stressful environment. That this is an adaptive process in that the infant needs to grow the kind of brain that she or he will need to survive in a stressful world. So the infant is able to interface with the environment through that exposure to cortisol, and it triggers the development of a brain that will be more responsive to stress, that will be more highly tuned and sensitive to danger in the environment. What we see is that in fetal programming theory, systems that are under rapid development are more susceptible to changes from cortisol. And if we look at this graph here, this is looking at the development of the embryo and the fetus, and that central nervous system is under rapid development from week 3 right up to about week 22. So for a little bit more than half of the pregnancy, that central nervous system is undergoing rapid developmental changes. And so structures in the central nervous system are more likely to be impacted by that cortisol. And so taking a look at how trauma during gestation or how that exposure to cortisol in utero affects brain. So the first thing we see is that increases in cortisol is linked with development of a larger and more reactive amygdala, particularly in girls, which is interesting. So one standard deviation is associated with 6.5% more or less increase in the right amygdala in girls. And this is particularly associated with processing fear. And we know the amygdala as a whole, its primary function is to process fear and activate the fight, flight, or freeze response. So again, this makes sense. If the prenate is going to be born into a dangerous and stressful environment, the brain's primary function is to protect our survival. So survival of the individual is going to depend on having an amygdala that can very quickly detect threat. And until the brain is able to ensure the survival of the individual, all of those other the development of the cerebral cortex is really just icing on the cake. It doesn't matter to have logical thought, creative processing, artistic ability, executive functioning, if that ability to respond quickly to fear is not taken care of. So the brain is prioritizing survival of danger over higher processing. We see that the larger amygdala volume is associated with anxiety disorders in school-age children, and that gray matter is affected, so that cerebral cortex is smaller in children who are born to mothers who are in stressful environments during gestation. And the brain is constantly needing to prioritize as it is growing in utero. Am I growing a brain that is going to help this person in survival, or can I use these resources for cerebral cortex and higher functioning? It's not only about the development of brain structure during gestation, but we also see that the relationship between mom and baby begins during gestation. So chronic stress during pregnancy is related to delivery complications, increased rate of cesarean section, preterm birth, and low birth weight. And all of these things affect the mother-baby dyad in the early hours after birth. We'll talk about that in a future slide. How these high-tech deliveries or preterm birth and NICU stay can impact the interaction during mom and baby very early on. We see that infants who are exposed to toxic stress during gestation are at an increased risk of developing behavioral and emotional disorders, and that stress that happens during the third trimester, that during the third trimester, prenates of mothers with histories of child abuse have lower resting heart rate variability. So we're seeing here a decreased parasympathetic activity, that ability to rest and digest is lower in these babies. Looking a bit at mothers who have been exposed to domestic violence during gestation, who were not exposed to DV during pregnancy. So again, looking back at how these early experiences affect the intergenerational transmission of trauma, even if the prenate is not exposed to that domestic violence. We're seeing poor quality of attachment between mother and fetus, even when DV was not experienced during that pregnancy. We have that increased maternal heart rate to infant crying. So again, that decreased maternal sensitivity, that decreased ability to regulate and be responsive to the infant, and overall poor infant regulation at 6 months of age. So shifting a little bit from looking at how mom's early experiences, from looking at how experiences during gestation affect the development of the infant, and looking a bit at how the birth experience itself impacts the mother, the baby, and the relationship between the two. And so I just want to take a moment to pause here and introduce you to Robin Lim. If you have a moment in your own time, There's a beautiful trailer on YouTube for her movie, Gorilla Midwife. I would encourage you to just watch that clip. Robin Lim is really a pioneer in helping us understand how not only the outcomes of birth, but the actual experience of the mother during the birth process impacts future generations. And she is quoted as saying that peace on earth begins with birth, and really looking at how we need to shift to a more process-oriented model of the birthing experience, that what the mom and what the baby experience during the birth process really has long-term effects. So what does birth look like in a typical medicalized birthing environment? And I do want to pause here and say that it's important to note that this is not across the board. There are absolutely providers who take a trauma-informed approach to birthing, who take a physiological approach to birthing, and really are very mother-baby centered in this experience. And so what I'm going to talk about are typical experiences, but I want to acknowledge the many, many wonderful providers who do not practice in this way. And I can think of many in New Jersey. I want to make sure that they are acknowledged, that there are many who are really working hard to do things differently. So in the typical modern medicalized birth experience, birth is seen as a pathological process that needs to be managed and monitored rather than a normal physiological process. So I chose the image on the right here of the mother and baby giraffe because it reminds me of how when there is a rare birth in a zoo, I'm thinking back, there was some pandas that were born a couple of years ago. The zoo went to great lengths to make sure that the mom panda was not exposed during the birthing experience, that the scent of humans was not nearby, that the environment very much, she was alone, she was safe, it mirrored what her natural environment would be. However, we don't do that for the majority of our own mothers who are birthing in the hospital. Moms are expected to go to a place that is associated with illness. They put on a gown that they may have worn something similar last time they had a surgical procedure or in the emergency room. Different smells, antiseptic smells, strangers who are providing services. And in particular, when we think about families who are birthing within a clinic environment, they're most often not provided with one or a team of obstetricians that they get to know during pregnancy, but are working with a different set of individuals during pregnancy, and the doctor that they have once they're in the hospital, this is often a stranger. And so thinking about how that creates a sense of danger, and then the amygdala, as we talked about before, that amygdala, it's a fight, flight, or fear. And so how do we expect families to birth babies when they're not feeling safe? We don't expect that panda to do it, but we expect humans. The modern birthing environment is also motivated many times by economics and fear of malpractice. So looking at how fear of liability or the impact of insurance on decision making, that this all plays a strong role in how decisions are made within the modern medicalized birthing system. We tend to see a high-tech, low-touch birth. Very typically, medical staff will come into the room and eyes are on the fetal monitoring strip, or eyes are on the screen that mom is hooked up to. They're not really taking a look at mom and her expressions, or asking her to really share what her experience is, how she's feeling about things. We also have a tendency to value the information that is given to us by a fetal monitoring strip or an image on an ultrasound, as opposed to mom's intuition or mom's perceptions of what's happening. And I'll share a story here of a birth that happened at home and how mom's intuition was right in this situation, and how our modern medical system really devalues mom's ability to follow what her instinct is telling her, what her gut is telling her, what her body is telling her, being hooked up to machines and needing to stay in bed, or perhaps having medication that influences her ability to move. So this birth was happening at home, and there was an experienced midwife who was there with an apprentice. And mom was on her hands and knees, and she was pushing. And the experienced midwife was up by mom's head, and the apprentice was down by mom's bottom, and the baby was starting to crown, and the head comes out. And the apprentice sees that the baby's shoulder is stuck. This is shoulder dystocia. It is one of the truly life-threatening emergencies that can happen during the pushing phase of labor. And the apprentice looks to her supervising midwife, that this is an emergency, please come here. Mom is facing away and does not see the apprentice midwife's face. She is not aware that there's an emergency at this point. And mom, without knowing, gets up, and she stands up and kind of does this chicken leg move, which dislodges the shoulder, and the baby pops out and is caught by the midwife. So when we create a sense of safety, mom's bodies know what to do often. When we create a place where mom is able to tune into what her body needs, the physiological process often unfolds without intervention. And so the patriarchal views that are embedded in an economically driven decision-making process, or where fear of malpractice is affecting decisions, these patriarchal ways of doing birth really devalue body wisdom, and in many cases actually decrease safety. And it also really takes away this idea of labor as being something that is emotionally important, that the process of birthing in and of itself is a rite of passage in becoming a mother. And so what we're looking at here is, what kind of knowledge are we valuing? In a patriarchal, economically driven system, we are very often valuing data, machines, things that can be quantified, and devaluing a mother's body wisdom. And often when the system kind of at its at the far end of the spectrum, what we see is what is called obstetric violence. This is a term that was adopted in Venezuela back in 2007. And in Venezuela at the time, we were seeing very high maternal and infant mortality, terrible experiences of birthing. And so a group within the country said, we need a word for this. We need something to call it, because very often these experiences of mothers are being pushed aside as, this is part of the medical system, or we know best, and this is just the way things are done. But by naming it, they really gave power to individuals to be able to really put a label to what's happening. And so what do we mean by obstetric violence? Dehumanized treatment. So where an individual is not given choice, is not given voice, when there are policies and procedures that are not evidence-based. For example, if we look at individuals not being able to eat and drink during labor, and the fact that this often leads to increased C-sections or vacuum or forceps extractions, that these are not evidence-based, and they lead to increased complications for mothers. Pathologizing natural processes. So the idea that the words that we use, the way that mom is treated during labor, makes childbirth and pregnancy more like an illness than a natural process. If we look, for example, one of my least favorite books and also most read books, What to Expect When You're Expecting, really talks about the symptoms of birth. How often do we hear this term? Symptoms of pregnancy, symptoms of birth. It kind of goes by a day-to-day, everything that can go wrong, where these processes are things that will may be unpleasant or they may be pleasant, but they tend to unfold in a healthy manner if they are just left alone. We see a loss of autonomy or a mom's ability to decide freely. It's important that moms are educated in their rights in childbirth, that birthing families are able to have informed consent, and to know that informed consent means being given the risks and the risks and the benefits of any procedure and being allowed to freely decide between those. Very often in my time as a doula, a client would be given a suggestion for an intervention. We might want to try Pitocin here, and needing to really draw out of that provider, can you share what the risks are? Can you share what the benefits are? Can you help this person make an informed decision with the full range of information? And that doesn't happen on a regular basis. Going a bit farther than that, we see that it's not only about having information, but without informed refusal, there is no informed consent. So individuals need to be able to say no or to say yes with a full range of information. We also see obstetric violence when the mother-baby system are seen as separate entities. There's very often this idea that what's good for mom is not good for baby, or that it is harmful for the baby, that the mother's body is a dangerous place, and there is this rush to separate the two of them as quickly as possible. Whereas the vast majority of the time, what mom is seeking in labor, what is good for her, is most often actually very healthy for the baby as well, that they are an interdependent system and not two separate entities. And as we're going to talk about in a little while, not only during pregnancy and childbirth, but even during that postnatal, the perinatal period as well. And ultimately, obstetric violence negatively impacts the quality of life for the mother-baby dyad. Some examples. We talked about informed consent and refusal, withholding or misusing information. There have been times as a doula where information about the risks of a procedure were withheld, or a client was told, oh, there's really no risk here, when data does show that there are inherent risks with a particular intervention. Another example is sexualizing procedures. So I think the most common example that is given is the idea of the husband stitch, where after birth, any tearing in the perineum very often will heal on its own, especially if mom is able to have adequate rest. But the idea of suturing, even sometimes going so far as for that to be done in the vein of the husband's continued pleasure with having that area be quote unquote tight, is a sexualizing of procedures. There are also times where I have witnessed providers making sexual comments or not honoring a mother's desire to be covered during labor, or we often see just sort of like sitting in front of the mother's open legs when the provider could move away and give that mother that personal space. Use of the body for teaching. In my experience as a doula, I have seen that mothers with Medicaid are the ones who are often offered up for residents to learn. There was an experience where one mother had 3 or 4 different residents come in and attempt to give a vaginal exam without consent, that 3 or 4 different residents would be putting their hands inside of her body to check her cervix. Restraint of the mother for physician convenience. So if we look at the most common birthing position, which is lying on one's back with feet in stirrups and knees up, this is the most convenient position for a provider to sit comfortably on a stool and with a light have a view of what is going on as the infant is crowning, but is likely the least physiological normal. We don't have gravity working in order for the baby to descend. We have a situation where a mother needs to push the baby over the pubic bone rather than, if it's a hands and knees, there's an eased exit of the baby. We also don't have movement in that situation. We see that the pelvis is actually very, it's flexible and will stretch as mom is moving. If she's able to walk and squat and move as her body desires, that facilitates a more comfortable and quicker birth experience. However, these things would all mean the physician getting on the floor or the physician not having as much control over the experience. Refusal of medical care, especially when the birthing family's desires either are things that the physician may be uncomfortable with, they may be less experienced with, it may be less convenient for them, it may take more time, that medical care can be refused in these situations, if disrespectful language is used, and then also blanket policies that restrict forms of care. There are some hospitals where there is just a blanket policy that mom is not allowed to walk during labor, regardless of her status of taking pain medication, that puts the hospital at risk for fall, and so that is disallowed, even though walking is an evidence-based process for a healthy and low intervention birth experience. And so this quote here, "The tree remembers what the axe forgets." This is an African proverb that really talks about this idea of obstetric violence being a situation where, for the medical provider, this may be just one of many people who are birthing within a day or a week, but these experiences affect the mother-baby dyad throughout the lifetime. Just going to do a quick time check here. I tend to lose track of time, so I'm going to pick up the pace here just a little bit. Postpartum PTSD is common following traumatic birth experiences. This happens when a birthing person either was or believed that they or their baby were in danger of injury or death and felt helpless or out of control or alone during the process. So the important thing here being postpartum PTSD can be diagnosed even if there wasn't actually a life-threatening experience, if that was mom's experience. That's the way she perceived it. Risk factors, race being on the top of the list. A Black birthing person is 2 times more likely to experience a near miss during birth. 21% of Black birthing people report sometimes, usually, or always being subjected to poor treatment compared to 8% of white birthing people. Other risk factors are a trauma history, experiencing obstetric violence, or feeling like they are not part of the decision-making process, use of medical jargon, or talking over the birthing person. This is a survey that was designed at my program by myself and Dr. Emily Bosk. I'm happy to share this with individuals. It takes a look at the individual factors that are associated with postpartum mood and anxiety disorders and helps us to assess how many of these factors individuals have been exposed to during the birth experience. And when we have a traumatic or a high intervention birth, that often limits the interaction between mom and baby in the hour or hours after birth. This comes from the work of, I'm blanking on his name at the moment, Nils Bergman, excuse me, Dr. Nils Bergman, who talks about the importance of connection in the hours after birth. If mom and baby are left alone, the infant will go through 9 different phases of crawling from mom's abdomen, actually inching their way up and flipping themselves over, touching the breast and latching themselves, which is involves movements that typically don't happen until sometimes 3 or 6 months of age. So if left undisturbed, the process unfolds on its own. What Nils Bergman promotes is actually skin-to-skin contact for the first 6 hours after birth or through a complete sleep cycle, that the infant would have the opportunity that there are these phases of alertness and connection with mom, and then a drowsy period, and then a feeding, and then a sleep, that the cycle should be complete. And what we see are that these first 24 hours with skin-to-skin contact, with breastfeeding if mom is open to it, are critical for the neurological wiring of mom for caretaking behaviors. We tend to say that mom is nursing the baby, but Nils Bergman says that the baby is actually nursing mom, that the skin-to-skin, the breastfeeding creates neural connections in mom that promote caretaking behaviors. We also see that breast milk promotes myelin production, and myelin is a coating on neurons that actually protects against trauma. And important to note here that these first hours are optimal, but they are not necessary for wiring mom for these caretaking behaviors, for parent-infant attachment. These situations can absolutely be recreated down the line. A bit about perinatal mental health. So we see an association with the birth experience and postpartum PTSD. And there are many other aspects of perinatal health that impact the well-being of the mother-infant dyad. Important to note, emotional complications are the #1 complication of pregnancy. The most common complication is actually the mother's emotional experience during or following with postpartum with perinatal mental health issues. We see postpartum anxiety at 17.1%, 9% of moms experiencing the full criteria for postpartum PTSD, with 18% symptomatic, about 0.5% of mom experiencing postpartum psychosis. And again, we have these disparities with when it comes to race, with 38% of Black birthing people reporting postpartum depression as compared to only 13 to 19% of the overall population. So moving beyond just diagnosed perinatal mental health, mood and anxiety disorders, important to note some things here around typical experiences that can also be troubling to parents. It is very common for postpartum mothers and fathers to have intrusive thoughts. So fears that they might hurt the baby, or fears that the baby has stopped breathing, or fear that they might do something wrong or that they're incompetent. These are very common, and they are also very distressing to parents, with intrusive thoughts having a much higher impact on mom's functioning and feelings about herself than fathers. Fathers tend to be able to maintain their level of functioning a bit more than moms. And so we need to know that this is common, and that we're able to normalize them. So important to look at this with parents as, this is your protective system in overdrive. This does not mean that you're going to hurt your baby. What we see is that ego dystonic thoughts, so thoughts of harming the baby that are troubling to the parent. Oh my gosh, it bothers me. I had this image in my mind of me doing this terrible thing to my baby. What is wrong with me? These thoughts that are troubling to parents are not associated with any kind of aggressive or harmful behaviors. When we see ego-systonic thoughts, so thoughts such as, I'm no good, my baby would be better without me, you know, I'm a bad mother, and so my baby shouldn't be in this world to be exposed to me. When the thoughts are not troubling to mom or to dad, that's when there's a mental health issue and a concern for safety to the baby. As we're thinking about perinatal mental health, it's important for us to think about, how do our expectations of new motherhood affect our view of perinatal mental health? Just food for thought and further discussion at some point. You know, when we look at the 17% of moms with postpartum anxiety, almost 10% of moms with postpartum PTSD, we need to be careful not to pathologize mom, but to really look at the system that created the PTSD, or the separation of families in our modern, the way that we're living as individuals within households, that these are diagnosable at these rates, but that we're looking at systems and looking at social support and not just kind of what's wrong with mom. And so the birth experience and early adverse experience affect parent-child relationships. I'm going to move through this sort of quickly here, but looking at access to social determinants of health and their high correlation with parental stress, and parental stress being highly correlated with responsiveness to the infant, with the ability to attune to the infant and to respond in an effective way. And I think most importantly from this slide is knowing that the infant is not born with the capacity to modulate their emotional state alone. So this is a right brain activity. It is part of the cerebral cortex, our ability to shift our emotional state via our thought process, via distraction, via decide to engage in self-care. These are all things that develop in the cerebral cortex, and they happen, the developmental process begins for infants by being on the body or in relationship with a regulated adult. And so infants need to be exposed to regulated caregivers who have their basic needs met, who are in low stress environments, that are not exposed to domestic violence, that have enough time off from work that they can be regulated themselves. And the infant comes on the body, the infant relates to a regulated caregiver, and that is what creates the beginning of that brain development for the infant to learn as they develop to modulate emotions on their own. And this ability to modulate emotions is very much correlated with mental health, with substance use, and a lot of other problems that we see when we look at ACEs outcomes. So we look at the caregiver relationship, the parent-child relationship, as the infant's blueprint. The way that the parent perceives the child, the way that the parent relates to the child, forms their blueprint for how they see themselves in the world, for what they expect from others, for what they expect from relationships. If a parent has their basic needs met, if a parent has their mental health needs met, then they are able to attune to the infant's needs, understand what the wants are, have the emotional capacity to respond effectively. That infant grows up learning that they are worthy of being responded to. When the infant cries and the parent responds, that infant is learning self-efficacy. They learn that they can have control over their environment. They learn that adults are safe. They learn that relationships are safe. And this becomes the beginning of identity development. Key here being, identity development happens within the context of relationship to their primary caregivers. And that these early relationships also provide what we call the psychological immune system. So beyond just that attunement and that effective response, we also see the importance of parents getting it wrong, of what we call a mismatch, and then moving to a repair. So what creates the resilience is that an infant can learn, let's say that, baby is in a bouncy seat and mom is doing the dishes and they're cueing that they're hungry, but mom can't get there quite right away. We have a mismatch. Infant is asking, mom is not able to respond right away. Infant begins to get a little bit dysregulated. Mom says, all right, I really need to make a bottle for this child. They're maybe singing to the baby while they're making the bottle. The infant learns, I can be distressed, but it doesn't go too far and it doesn't go too long. And then I am responded to effectively. There is a repair and I can feel good again. So this idea of resilience is I can tolerate distress within normal limits, and then I can come back into relationship. I can feel good. I can tolerate distress, and I will be okay in the world. And so looking at the way that we are intervening with mom and baby, some takeaways here is that we need to shift away from parent education to building the capacity for connection. Certainly, parenting skills do play a role, but what we see more often is that this is not a cognitive issue. That is not so much around not having information, but having the capacity, having the ability for the parent to be emotionally regulated, to have their needs met so that they have the capacity for connection with the infant, that they can stay within the interaction when there is a rupture, that they can tolerate the distress of the moment and stay in the interaction to complete the repair. And so the question here becomes, who holds the mother in this interaction? We're looking at mom and baby as being separate and interventions geared toward the infant and infant development, but the mother and the father, that primary caregiving relationship is the infant's environment. And so taking a dyadic approach where we are looking at the relationship between mom and baby as being the client and building the ability for mom to perhaps learn to tune into her baby's cues and understand the difference between an engagement cue and a disengagement cue, and for her to be supported enough that she can really sit and tune in and detect what the infant is communicating nonverbally and then have the capacity to respond. To help moms develop what we call reflective functioning, where she can see a behavior and become curious about the infant's experience, to empathically wonder what the infant's experience is and create curiosity around the meaning behind the infant behavior, where moms and fathers are able to respond to the need behind the behavior and not just react to the behavior of the infant, which is often or to the child, which can be difficult or disruptive. So for example, the infant is throwing a temper tantrum. If the toddler is throwing a temper tantrum, understanding that that is part of a normal developmental process, or through the lens of a 2-year-old, if they can't put on the shoe themselves when the 2-year-old's life goal at that moment is to develop independence, that temper tantrum does make a lot of sense. And then responding to that toddler's need for feelings of independence and not reacting to the temper tantrum itself. And so in closing, I love this quote by Bessel van der Kolk, that the parent-child relationship is the most powerful mental health intervention known to mankind. So within this parent-child relationship, we have so much access to patterns that are passed down intergenerationally and opportunities for new patterns to be developed, both within the parent-child relationship, in the infant, and within mom. and
Thank you, Carolyn. This information was so informative and so important to know. Again, as I said, I'm fascinated by this information, particularly the prenate's response to maternal emotions in utero and the effect of trauma on brain development. Just, it really starts way back when. So, I think this is really important information for all of us to have. I want to thank everybody for coming. And for being with us today. I want to thank Carolyn for that wonderful presentation. I'm hoping everyone will come back next week to join us. I'm going to, end here, but Carolyn, did you have anything else that you wanted to add at this point?
No, if anyone has questions or anything that comes up afterward, I can share my email with Karen and with Kathy. So if anything comes up after, I'm more than happy to connect after the presentation.
All right, terrific. Thank you again, Carolyn. Thank you, everybody, for being with us, and have a great day. See you next week. Bye now.